Hello, my name is Brett Shemak. I'm a State of Alaska certified EMT2, and my instruction project is on endotracheal intubation. Quick disclaimer on this: endotracheal intubation is an incredibly invasive medical procedure that should only be performed by medical professionals. The following instructions are meant to be an overview for people already well trained in human anatomy and physiology. Please do not attempt an intubation without the proper training and certifications. Okay, the most important part of any medical procedure is protecting yourself with your personal protective equipment. To perform endotracheal intubations, you should have nitrile gloves, eye protection, and a face mask. It's essential to protect yourself from exposure, especially during airway procedures, as oftentimes the patients will be performing some sort of respirations on their own, which can send all sorts of sputum back up your way that you really don't want inside of your own body. The first step is to open the airway. After you open the airway, you want to visually inspect for any obvious obstructions. If they can easily be removed, go ahead and do that with your fingers or with some Miguel forceps. You will then size and measure, and then insert an oral or nasal pharyngeal airway. This does two things. It allows you an easy airway as you prepare for your intubation, and it confirms that the patient has no gag reflex, which is a requirement to perform an endotracheal intubation. After you have a basic life support airway in place, i.e. the nasal or oropharyngeal airway, you will attach a bag valve mask to high flow oxygen, which is 15 liters per minute. And then this is where your second person comes into play, and you'll have your assistant ventilate at 10 to 12 breaths per minute. It's essential that you keep breathing for this person as you get your equipment ready. Any time that the human body experiences without oxygen flowing into the body can do severe damage to all sorts of systems, so it's best to just avoid that problem entirely. You will then gather your necessary equipment. This includes a laryngoscope blade and handle. There are a few different types of laryngoscope blades. The one pictured here is a Miller blade. There are Mac ones as well, which have a slight curve to them, and the difference in that is just a matter of where you place it when you go to insert the ET tube. There's also some video ones that I have pictures of later that aren't generally standard. However, they do offer great visualization for this process. You'll need a properly sized endotracheal tube with stylet. Most adults will be between a 5 and a 7.5 centimeter tube. You'll need a 10 cc syringe, medical grade lubricant, capnography measuring device, and a tube securing device, along with a stethoscope pictured there. Your next step is to ensure the proper function of all of your equipment. This includes attaching the laryngoscope blade to the handle and checking the light. The laryngoscope blade and handle pictured here has a fiber optic cable that runs light down so you can see into the patient's airway. Some of the older equipment has a more traditional light bulb screwed onto the end of it. Oftentimes that light bulb can come loose and has the potential to fall into the patient's airway as you're attempting to perform an intubation. You should be familiar enough with your equipment to know whether or not you have that. And if you do know that you have one of those bulbs on the end of your laryngoscope blade there, make sure that it's properly tightened and secured before you start this procedure. Make sure you disconnect the blade from the handle to save the battery. You will then inflate the cuff on the tube with 10 cc's of air and ensure that it holds a proper pressure. Your next step is to insert the stylet into the endotracheal tube. There's some different theories involved here in the shape and style of your tube with the stylet inside of it. However, the default is to form it into an L shape to give you the leverage and the position that you need to advance the ET tube into the patient's airway. Ensure that the stylet does not protrude from the end of the tube and that it is well lubricated with your medical grade lubricant. Being that this is an invasive procedure and your airway is just naturally delicate, both of those are to ensure that you do as little damage as possible to your patient's airway as you advance the tube. You will then have your assistant pre-oxygenate your patient. Pre-oxygenating packs the lungs full of oxygen that will hopefully be used during the time that it takes you to intubate your patient. Have your assistant breathe for the patients at 10 breaths per minute via the bag valve mask, which is about a breath every 3 to 4 seconds. You will then begin your intubation. Use your laryngoscope blade and handle. Insert it into the valleculae, which is a little pocket above the epiglottis and between the tongue. You will lift forward in a pulling motion, making sure you do not rock back onto the patient's teeth, and visualize the vocal cords. Pictured here is one of the video laryngoscopes, and you can see A little bit of the tube going into the vocal cords there. On the next slide I have a better picture that shows that pretty well. Once you visualize the vocal cords, advance the endotracheal tube with the stylet approximately 3 centimeters past the vocal cords. Here's a close-up picture of that with the tube going past the vocal cords there. The vocal cords obviously pictured as the hole with the white lining around it and the ET tube going through those. You will then inflate the cuff and check for placement. A couple different ways to check for placement. The first one is to, well, obviously you have to remove the stylet so that you can have air flowing through it. You will attach an inline capnography measuring device. This capnography measuring device measures the CO2 coming out of the body in millimeters of mercury. And typical reading for that would be 35 to 45 millimeters of mercury. And if you see that capnography reading anything, it means that your tube is placed properly and is not going into the gastrointestinal tract because there's no CO2 coming out of the gastrointestinal tract. You will auscultate the gastric region first. And the reason you do that first is if you're pumping any air into the stomach, you want to know that right away so that you can remove the tube and prevent any further harm. If you auscultate the gastric region and you don't hear anything, you will then move on to the lungs and you will listen to all regions of the lungs to make sure that you hear airflow. You will then secure the endotracheal tube with what is pictured here as a tube check device, and then you will continue ventilations at 10 to 12 breaths per minute. This has been a basic overview of how to perform an endotracheal intubation. I'd like to thank my lovely assistants, Kyle Fagerstrom and Yvonne Veronin, for the help with the pictures here, and hopefully you learned something from this. Thank you.